we have plenty of laxity of the proximal leg to get a primary closure on the leg donor site wound. But what we're going to do is we're going to actually take a skin graft off the proximal skin paddle and use that to replace the skin that's being taken out as the skin paddle of the distal leg, where the skin is much tighter and we won't be able to get a primary closure. If we put the deepithelialized skin paddle in the floor of mouth for the floor of mouth reconstruction, it does very well as a floor of mouth mucosal substitute. And this avoids the donor site morbidity of taking an extra skin graft off the thigh wound. So we're going to make our superior, anterior, and inferior skin incisions. And in the proximal portion of the flap where the skin paddle has been deepithelialized, we're going to actually make the incisions along the edges of the portion of the flap that has been deepithelialized, so that when we close the wound, there's no deepithelialized wound left on the leg. This dissection initially is done in a suprafascial plane. I'm a big fan of leaving as much leg fascia as you can, because the skin grafts that we use to reconstruct the donor site wounds on the leg heal much better when they're placed on fascia as opposed to tendons. So in the distal aspect of our exposure, the peroneus longus muscle tendon is prominently visible, and that marks where we make the subfascial incision to expose the peroneus longus muscle. So go ahead and make an incision right along the midsection of the peroneus longus tendon. So at this juncture, we can usually go ahead and visualize the perforators to the skin component of the flap. I'm going to retract the skin paddle and fascia posteriorly, and we'll tease the peroneus longus muscle anteriorly. This exposes the posterolateral intermuscular septum of the leg, and the branches from the perineal to the skin component run in this intermuscular septum. And so now you can see the periosteum of the fibula is beginning to get exposed. Smaller blood vessels that we come across during this dissection can be controlled with a monopolar cautery. When you come across larger blood vessels like this one, we use either ultrasonic shears or bipolar electric cautery. By doing this, we will expose the intermuscular septum that separates the lateral compartment of the leg from the anterior compartment of the leg. So as you approach the proximal end of the dissection, you want to keep your eyes open for the common perineal nerve, which runs very close to the lateral aspect of the fibula bone and is usually exposed as you proceed proximally. And I'm going to go ahead and lift the common perineal nerve up off the fibula bone and retract it anteriorly. And so here you can see the common perineal nerve, which has been exposed and is now being retracted up off the lateral aspect of the fibula periosteum. And now I have now exposed the intermuscular septum that separates the lateral compartment from the anterior compartment, and I'm going to go ahead and incise that septum to enter into the anterior compartment for the next portion of the dissection. The tibialis posterior muscle usually ends somewhere down near the site of our osteotomy. And the important thing to recognize is that when the tibialis posterior muscle ends, there's no longer any soft tissue separating your scissors from the distal perineal artery and vein. And so at this point of the dissection, I go a little bit more slowly with more blunt dissection. So we're now coming down onto the soleus muscle. I'm going to reposition these Zallis clamps onto the posterior aspect of the skin paddle. We're now going to dissect right down onto the soleus muscle, which is this muscle right here. This plane of dissection is now deepened in the distal aspect of the leg into the plane that separates the soleus muscle from the underlying muscle, which is the flexor hallucis longus muscle. We're going to get into the plane between the soleus muscle and the flexor hallucis longus muscle. We will see little branches going back into the soleus muscle as we make this plane of dissection, which will need to be controlled. And so I like to make the distal osteotomy from anterior to posterior. The reason I do that is the distal perineal artery is often visible from the anterior exposure. We could actually see the distal perineal vessels right there at the tip. And so visualizing that directly, I'm going to pass the right angle retractor between the perineal and the bone, bring it out behind the bone, and then I have a very narrow malleable retractor which I'll pass through that same space to protect the perineal from the saw when we make the saw cut. So we make the cut with the sagittal saw. Now the proximal osteotomy I'm going to make using the same technique, using a malleable retractor to protect the vascular pedicle. This side is obviously more important than the distal side, because if we transect the distal perineal arteries, that's not a big deal. We're going to be doing that in a minute anyway. I don't want to transect the blood supply to the flap though, or else we'll have problems with ischemia time. So we're going to release the tourniquet. I believe it's been about 106 minutes. So once the tourniquet down, obviously any vessels that we may not have controlled will start to bleed. You can check the flap perfusion and you can see immediately the skin paddle is bleeding well. So now that we've released the tourniquet, we're going to carefully look at hemostasis both in the flap as well as in the donor site wound. We leave the fibula attached by the perineal artery and perineal vein until the tumor resection is done, and that avoids a long ischemia time. So I'm just judging where this will close primarily without being under too much tension. You really want this to be pretty much tension-free. Some legs tolerate being closed under tension, but that is not the case for fibula flaps.